They talked about, asked people what they wanted to present to a group of clinicians that treat adults. And so I see a lot of adult patients with ear pain, and I think there's just a few things that make them very different than kids. And this talk will be about ear pain in adults and how they may be coming in with ear pain, and in their mind, they immediately say, I have an earache, and then that means I have an ear infection, which means when I go to this doctor, I'm gonna get an antibiotic. And they've already run through that whole thing before they ever even made the appointment. So when they come, I think we need to make sure we don't also make the same presumption that their ear pain is an ear infection, because in adults, we're probably not gonna be seeing that a lot. So that's the problem with pain. So we're going to review the external ear and middle ear anatomy very briefly, just in an effort not to remember all the names, but to just remember what the anatomy is supposed to look like and how it would be different in an infection. And then that will hopefully help us understand the pathophysiology of acute otitis media, which is going to be rare in adults, and otitis externa, which is going to be a bit more common. And then we'll identify some things that I think we're all seeing in these ears that we think are painful that are not. And then the common non-otologic conditions that people are going to come in with ear pain. So in the lower left of this, I do that thing where it's the right because that's the patient. So if I say right, I might actually be meaning left. Okay, so on this side, the lower image shows the ear canal. And the most important part of the ear canal anatomy for clinical use is that the skin is really tightly adherent to the cartilage and the bone. There's not a lot of cushion between that skin and those underlying hard tissues. And so when you look at an ear canal, you should just see the shape of the canal. And if it's perfect, it might not even look like there's much skin there. It's not a thick tissue. As you run down the ear canal, you're going to hit the eardrum, and the eardrum should be thin and transparent as well. But because there's a lot of ear infections in children, sometimes we'll have scarring on the drum, and that can lead us astray. And then as we get past the eardrum into the middle ear, we have our hearing bones and their connection to the inner ear. So this canal view is really all we're getting in our clinical exam. When we look at the middle ear, we're really just looking through the eardrum, and all we're really going to see is that clear eardrum or that scarred eardrum and a portion of the malleus. And I think it's hard sometimes to get a good exam because people have all that wax in their ears, and it can be difficult. But we really have to try to get an exam because our clinical picture isn't going to delineate these things. The person that is convinced that they have an ear infection has already related it to like the one side of their nose being kind of stuffy, and then that person had a cold, and they've already made the whole story up. And if we don't really do our exam, we won't be able to get the right diagnosis. So, and then acute findings should be obvious. If they really have an otitis media or acute otitis externa, it should really be pretty dramatic, and I'll show you as many pictures as I could find of what those look like. And then I think the last thing is we really do need to be confident about what is not there, because our patient thinks they know what they have. It's really easy to just go, yeah, all right, here's some, see you later. And unfortunately, if it's most of the causes of non-otologic ear pain, they're going to come back over and over again and get a lot of antibiotics they didn't need. So here are some pictures of truly painful ears. The top right is otitis externa. Acute otitis externa is dramatic. It will really make it so you can't see much. You'll look in there and the walls will be caved in and thickened. They're not thin, like you see this thin down here where you can see the canal wall up in that top right. It's very, very, very thickened. The drum will be thickened. Sometimes you can't see where the drum is. Sometimes you only get a couple of millimeters in and it's all collapsed. and they're dramatic. And then in the bottom right, acute otitis media, also very dramatic looking, bulgy eardrums. You can see the canal around there is all fine. It's not swollen. All that problem is on the other side of the eardrum, and it's so bad that it'll bulge and discolor the drum and really be very dramatic. And then this last one, we won't talk too much about this, but acute ruptures. This, you can see how injected and red and painful that looks. And this is a couple days after a closed hand rupture to the drum, and this person's not even really in pain anymore, at least not by the drum. Okay, so the ears should be dramatic if they're hurting. Just to give an idea of what we're looking at, acute otitis media, yeah, it's really common, but 97% of those cases are children. If we look at all of the adults with an acute otitis media in a year, they're going to be half of the adults we see with acute otitis externa. So acute otitis externa is going to be our main infectious adult painful condition of the ear, and that half of those are going to be kids. So on the acute otitis externa, that is an equal thing, adult and kids, and going to be far more common than seeing an adult with acute otitis media. The pediatric literature and guidelines are really emphasizing not going to antibiotics as quickly, even in children. The pneumococcal vaccinations and some other things have made it maybe okay to not be really reflexively giving antibiotic for even kids with acute otitis media. And they've said, look, if you don't have a bulging drum, you don't give an antibiotic. A little bit more about acute otitis media, just so that we can further emphasize why it's not happening in adults. So by age 3, 5, and 6, kids are going to have at least one episode of acute otitis media. That means our adults are going to have some scarring of their eardrums when they're past these ages. By age 3, 1 in 15 are going to have had so many acute otitis media that they need ear tubes. And again, dramatic, bulgy drum, thickened drum, and painful. But again, 83% of kids, if you look at the adult incidence of acute otitis media, it's 1 in 400. 0.25%, really uncommon. This is the reason we shouldn't be seeing it in adults. So kids have a much shorter eustachian tube length. It's about half the length of the adult. It's not angulated like it is in an adult. And then, this is this tube that's connecting the back of the nose to the ear for aeration. And in the back of the nose in a kid, you have this giant adenoid pad. And this is a nice clean one. I mean, this is usually a gooey mess. And then right in this little pocket here is the eustachian tube opening, and it can just go right up into the middle ear. In an adult, we're elongated, we have some space, our adenoid is probably regressed, and we don't have the immune issues either. So as adults, we're better at fighting encapsulated organisms, and so we're just totally different beasts. Even in children, it's going to be your younger children. And I just had to put this in because 2.5 in 1,000 is basically the rate of acute otitis media in adults. So if you're seeing a lot of hairy elbows and jumping Frenchmen of Maine and these other rare conditions, that's about how frequently you should be seeing an adult with acute otitis media, not very often. If you see an adult with acute otitis media, they usually have one of these top things, something causing eustachian tube dysfunction, whether it's a history of a repaired cleft palate, Down syndrome, if they're a smoker, allergy, chronic sinus, if they're that patient, but on top of that, they got a cold or something, then you might see an acute otitis media in that person. And then I do see acute otitis media in my practice. They're generally these immunosuppressed people, immunodeficient people. And very frequently, you'll see this person who's been diagnosed with like 5 acute otitis media, and they're in your office with one, and you'll say, how's your hearing? And they'll be like, my hearing's fine. And you're like, okay, I was just checking, make sure you don't have acute otitis media, because they really would not be able to hear well if they're having the pain that they're having from an acute otitis media. The way this thing starts, and we don't remember because the last time we had them we were 3, but if we could remember it, we would start with a stuffy ear, a little bit of plugging, it would grow from there, and the last thing we would have would be pain. And we'd still have that hearing loss. And then that pain would diminish, and then we'd stay plugged for a while. And really, an acute otitis media is a 3-week event. It doesn't come and go. If you saw someone, if they started with their problem 3 days ago and you're seeing them now, they should still have findings. It doesn't clear quickly. So here's some dramatic acute otitis media. They should really look like this, bulgy, painful, and with hearing loss. And then I'll go by this once here, but then we'll talk about it in a minute for the acute otitis externa. Sometimes you look in that ear, and this image on the right where it says if it ruptures and draining, the walls will not be swollen shut. Sometimes it's hard. You look in that ear and there's all these secretions. And in my office, I take them to this room and I section their eardrum, their ear canal out, and then I can see this. In a setting where you don't get to do that, there may just be bunches of secretion in the ear. And I think the way to try to differentiate an acute otitis mediated with rupture and an acute otitis externa is really just to look at those walls. The walls will be very thickened. There won't just be like the canal and then a bunch of goo in the center. It'll be thickened all around for an acute otitis externa. And if you just see secretions and really the walls seem to be where they're supposed to be, you might have had a rupture with drainage. Here's some things that people come in with, and maybe they are complaining of ear pain when they have these, but these are not sources for pain. So up in the upper left, is that correct, left? There is some fluid in the middle ear space. This website, I took this off of, they're so kind, they like circled all the little air bubbles. And so you can see these little bubbles, and these people may have had pain a while ago, but this is no longer a painful ear, it's no longer infected, and it doesn't require an antibiotic. This person, really could be on decongestants and that kind of stuff. The middle one is a mass behind the drum. This is a cholesteatoma. It's a type of skin cyst that kind of acts more like a tumor, and it's not painful. That's the unfortunate thing about it, because they don't know they have it. And then the last one is someone who may be a person who took their eustachian tube dysfunction all the way into adulthood and have these collapsed drums, and that these are not painful ears. They're very dramatic looking, but they are not painful. So if an adult really does go into their, if a person goes into their adult life with eustachian tube dysfunction, they will show it. They will have scarring. Oh, I got this new little thing. It's called a cell scope, and you hook it to your iPhone, and it has a little otoscope thing, and you can actually, these are pictures I took of, do you guys have these? They're very cool. And so I had, this patient is really tender ear, so I had to go to a pediatric size otoscope on there. But you can see this tympanosclerosis on the right side. This is sclerosis with a chronic perf. And these are different people. And this is a previously repaired drum, a new rupture. And so if an adult really says to you, oh, I have these infections all the time, I've had them since I was a little kid, they should look bad. They should look like they've had them. And then really just a reminder, if they have a history, like they think they have an ear tube instill, or they have a history of a TM perforation, we really should not be irrigating those ears. You will kind of create a doozy of an infection that way. So again, more on chronic otitis media. These are those adults that say, I have been infected 20 times in my memory, and they should look like this. They shouldn't look good. So chronic perfs, granulation tissue, scarring, and again, these ears are not painful. Here's an ear that's collapsed. Up in the attic, you can see the outline of the bones, and even the bones around the attic portions of the ossicles are eroded. And these people may be completely adjusted to the fact that they don't hear out of an ear, and some of them don't have ENT as part of their life, and they really probably should, because this bony destruction is headed superiorly, and just on the other side of that is their brain. So these people really do need to be watched, even if they are like, look, I've had 2 surgeries, I'm not doing that again. We should see them every once in a while and just make sure they're not having problems. So our first adult with ear pain. So really these adults will have ear pain. It's the most common painful ear condition in adults. And again, we said there's 2 million of them, 1 million of them are in kids and 1 million in adults. We will see, even in Arizona, a spike in these. This isn't Arizona data, but even in Arizona, where we've got a longer swim season, we'll see a spike in the summer months, and half of these will be then, and half will be distributed over the rest of the year. There is a clinical practice guideline. I don't think it made it into your packet, and if you're wondering about, here in a minute, I'm going to be lots of the slides that are in your packet won't be in there because I timed myself and it was way too long. So some of what you have won't be in here. The topical treatment only is what the guideline is really emphasizing, and really even with a fairly dramatic acute otitis externa, you only need topical treatment. This is from the guideline. It basically says an acute otitis externa is a rapid onset problem. It comes on within a day or two, really bad, from normal to looking as bad as that ear does. Very, very swollen canal. You can see some secretion sometimes you don't, but you will just see these walls of the canal just swelling shut. If you look in that ear and you're not sure what you're seeing, look at the other one, because it shouldn't have the same problem, and you can use them as a reference. These can swell so shut that when you go to do your topical therapy, you're afraid it's not going to get into the ear, and we'll talk about how to get around that. You can have swelling out here, swelling of the external ear, even a little swelling in front of the ear, and still treat this topically. It's usually bacterial, usually Pseudomonas or staph, or both. And so it's rapid, it's painful, it's diffuse. It starts from the edge of the canal and goes all the way in, frequently keeping you from being able to get an eardrum exam. You don't need to also cover them for a media just because you can't see their drum. You can just do topical treatment. And they give this list of the medications they think are fine, and they say any of them you can use, and then they give the cost on them. And I would just disagree a teeny bit. I don't think that the acetic acid solutions, and even with steroid, are very helpful for a true acute otitis externa. You really do have a bacterial infection there, and I don't think those are very helpful. They may be helpful for a more chronic condition, and I had some of that stuff in this talk, but it won't be emphasized today. So I primarily use Ciprodex. Yes, it can be expensive, but most of the time they can go on Ciprodex.com and get a coupon that you can put it in your script. If you're on electronic, e-scripting, you can put, Ciprodex.com to the pharmacist, and they can get a coupon for them. If they're on Mercy Care, it's covered. Some of the other access plans will not cover it as well, but they can substitute ciprofloxacin ophthalmic out if you want to do that. You can do ofloxacin, otic. And then the problem with the neomycin polymyxin, this cortisporin otic suspension, is that we'll talk about it in a second, but if they have a perforated drum or tube, it's an ototoxic med. So here's the WIC instructions. They come in these little teeny packs. They're Miracell. They're small. They're firm. They will go into a swollen canal. You do not have to see what you're doing with this. Honestly, they will never. You just put them in. They're just as long as they should be. You put it all the way in until the person is not going to like this. So you have to do it quick. So you tell them, you need to hold still, and you push this into their ear canal. You're doing this in a person that's so swollen shut, you can't. You're just going to go. It's going to go down the opening of the canal, and it'll go. You don't have to worry too much about this. And then you start your drops. And I think it does hurt a little bit more right before you do the drop. So if you have some drops in your office, it doesn't have to be, it just has to be something, if you don't have Ciprodex in your office, we all have them. But if you don't have that, you could put drops of saline. You can do anything to get this softened. It's the firmness of that otowick that really is painful when it's inserted. So you can moisten that up with something other than what you're treating them with if you need to. And then if you do not feel comfortable doing this is a call to an ENT's office, and you just say, I need you to place an otowick. And our front offices should be like, oh, okay, and they should get those patients in. So this is something we do frequently. So here's the neomycin problem. You start off with a swollen ear canal, and then they start putting cortisporin otic suspension in there, and then they end up looking like that. They're very displeased. And then you have this problem with the non-intact eardrum or a tube, and so I don't really use cortisporin otic suspension. These three lower ones are people that if you see this, even if they meet the regular clinical guidelines and they don't seem to be having an extra bad case of acute otitis externa, these people, the poorly controlled diabetic, the person with previous external beam radiation, or an immunocompromised person really does need to have a follow-up, and I would have them follow up within 48 hours. You can say, hey, you're going to be better in 48 hours, and you don't have to come if you're better, but they should have a set appointment to come back in. So this is a rapid on, rapid off. If they're not responding to medication, one, is it getting in? But if it's getting in and they're not responding, they need to be reassessed. And those 3 subtypes, the poorly controlled diabetic, the external beam radiation, and the immunocompromised person really could be at risk for malignant otitis externa, and that is a trip to the emergency room. So these are the sometimes painful, where there's a ton of fungal otitis externa, and we could do a whole talk on it, so maybe we will next year. And some of your handout has to do with this, but I'm going to have to skip over it to stay in time. So fungal otitis externa, it doesn't usually hurt, but it will start hurting when they start digging in there and flushing themselves out and buying stuff on the internet. These people can really mess themselves up. They've already usually started this by being a Q-tip user, and again, we'll do that talk next time. And then the foreign bodies, even if it's a bug, usually once the bug dies, it's not that bad anymore until they start to try to pick it out of their ear, and then you can have some pain. Foreign bodies are not emergent. If they're not infected looking, you don't need to do a drop. Just get them in with us, especially if it's down by the drum. This bug may have gotten down there by themselves, but lots of foreign bodies will get pushed down there, with people trying to get them out without good equipment. The only emergent foreign body in the ear is the lithium battery. They are very, very destructive. These little disc batteries, terrible. So these are emergent. Call right away. This must come out. So let's go to what we're seeing. So this gentleman came to me after being treated repeatedly for a number of ear infections. He got treated for a couple acute otitis externas, and he got treated for an acute otitis media, and he really didn't fit any of the presentation for those kinds of things. I told him to come see me when it was happening. So he currently is having on his right side a bit of discomfort in that ear and some itchiness, and that's really what he's been presenting to urgent care and PCP for. And so what he's being treated for is an acute otitis media, because they're seeing this white tympanosclerosis down along his eardrum, and then they're seeing the redness of his canal, and he's being treated. And really this gentleman just needs to stop using Q-tips, and he's causing all that irritation in his ears. He's just a little bit more aggressive on his right than his left. These ears are fine. And again, remember, all those kids that had those infections as little ones, they're going to grow up and they're going to have these scars. So here is some scarring, tympanosclerosis of both eardrums. And in this, I thought these were good pictures to see that, hey, you're going to evaluate the canal, and then you're going to evaluate what you see through the drum. And so you can see these canals aren't swollen. You can see almost the defines of the bone. And then even with the scarring, you can see around where there's no scar, there's nothing behind there, and there's no bulginess and no redness. So what are we seeing in all these people who are coming in with all this pain in their ears? We're seeing a lot of this. So there are all these sensory afferent nerves that travel through the ear on the way to where they're going, or there's a branch to them, and so we'll see pain in a bunch of different spots. And I like this drawing better. And so I've highlighted the 3 that I think I see the most, and they're going to be something jaw-related or dental-related, migraine, or other types of headaches. And then I kind of clump the cervical arthritis and musculoskeletal people together too, just to try to get them in the right direction as far as treatment goes. So here's our cases. Our patient number 1 is that's not her, but the next picture will be her eardrums. So this is a 33-year-old female. She had severe onset of left-sided ear pain. This would wake her up out of a dead sleep. She'd be fine. She'd go to sleep. She'd wake up at 2 o'clock in the morning with terrible ear pain. And she coincidentally is going through some infertility treatment and had stopped all of her anxiety meds while doing that. I'm seeing her, the pictures you'll see in a second are on day 2 of 10 of Augmentin. She's already had 5 courses of antibiotics in the last 6 months. And she has this history of bruxism and anxiety. Anxiety's not being treated, and she's not wearing her night guard. And she did have a history of having ear infections as a kid. And here are her drums on a day where she is in pain. This is a real person. I see these people like all the time. And There's nothing in there. There's no red bulgy eardrum. There's no red inflamed ear canal. Yeah, she has these cute little scars right down in here. Those nothing, and she's in terrible pain. She looks absolutely miserable, and honestly, she would love it for an antibiotic to just work, right? But she's going to have to do some other stuff. So I told her, hey, I really think this is your jaw problem, your bruxism. It's waking you up in the night because you're grinding your teeth and you're starting this whole pain syndrome. And I need you to restart your night guard. Go see the guy who made the night guard for you. And while you're not on your anxiety meds, you're going to need to figure something out. I am telling people to go on Insight Timer. I don't know if you've heard of this app. It's guided meditation, and it works. And then your ears are fine. There's nothing wrong with your ears. And reassure them that, you know, if they really had an infection, they wouldn't be able to hear. And her hearing's perfect. Okay. Number 2 is a 43-year-old male. He has really daily bilateral ear pain. That's not him, but it could be. And it's been going on for months. It doesn't go away. It'll get better, it'll get worse, but it never really clears. He's been on antibiotics, steroids, and Sudafed. He thinks that all 3 of those helped a little teeny bit. He doesn't have hearing loss, even though he has severe pressure in his ears. Now, some people will think they do have hearing loss, and that's a little bit of a glitch when you don't have an audiologist like right next door. So that can be difficult. But again, if they hear basically normally and that's not a main complaint, I think you can still go with that. So severe pressure in the ears. If you ask him, he will say that he is dizzied, he is somewhat nauseated. He does have these like visual complaints that are fleeting, and all of it started, you know, they'll usually say it started, and they'll know when it started, and then you kind of have to dig a little bit, like, well, what was going on then? And for him, he got this fantastic promotion, and he's flying all over the place. He's super stressed out, and air travel, the monsoon storms, fatigue, and stress are his triggers. He thought it was allergy, or told it was allergy. He had a test, it was normal, and he literally looks like that guy when he's in pain, and he just wants to stab his drums. And he did have a history of migraine in the past, but it's not like this. I know that this isn't my migraine because my migraines aren't like this. I hear that all the time. And here are his ears on a day where he feels terrible. So I don't know if someone was fooled by this little, you see this little wispy stuff on his drum. You can't see it as well here, but that is actually the imprint of a Q-tip, taking skin from the canal and shoving it down to the drum. And I don't go in my ears with a Q-tip. I don't do that. It's only out here. I'm not putting, and they look like that. So everyone's putting the Q-tip all the way in their ear. And so they need to stop that. But really, this is not a red inflamed ear canal. There's no red bulgy eardrum. These ears are not the source for his pain. And he doesn't fit the clinical stuff either. Months on end of ear pain is not going to be an ear infection. So let's go was this him? Yes. So migraine, of course, we've got a ton of it. Dr. Hurley was just talking about it for sinus. And so we just said we have 2 million cases of acute otitis externa in a year. We have 16 million acute otitis media. We have 22 million women with migraine. 7.2 million men with migraine. And unfortunately, it happens during these years where we're supposed to be making money, and so it's a huge economic burden. When the neuro-otology guys are doing studies on migraine meds, you know that they're seeing a ton of this. So they like to write papers of big skull-based surgeries and drilling and stuff, and they're doing a study on migraine. So they took 26 of their patients that are in their ear clinic, with dull, sharp, throbbing, mixed types of descriptions of pain, and 92% of them responded to either migraine prevention or migraine abortive meds. I tend to do the food stuff. I give them the whole migraine diet, the sleep, the water, you know, stop the caffeine stuff, at least not abruptly, maybe wean that off, and they will do better. And then this was out of Denmark. I think that this tension type headache and migraine, for lots of people, these are a blended thing, and maybe you'll see more men with tension type, but same thing. They're going to still potentially have pain in their ear. My last one is a 57-year-old male. He comes in with pain right at his mastoid tip, and it's dull but significant. It comes on, when it comes on and lasts for 15 minutes to an hour, and it happens on and off throughout the whole day. He does have hearing loss, but it's in both of his ears. He does have ringing, it's in both of his ears. It's been there for 10 years. It's a sign of just hearing loss in general. Both ears, a noise exposure thing that we're all gonna get. And allergy meds don't help. He doesn't have congestion, he doesn't have pop, he doesn't have ear pressure. He does have an inability to move his neck. He's got pain all up and down his spine, and most of all that started after a motor vehicle accident decades ago now, and he's had headaches since then. He thought he had that controlled through some chiropractor adjustments years ago, and he really wasn't linking these things, because before he really felt the pain more in his neck, and he hadn't really felt it at his mastoid tip, so for him it seems new. Here are his eardrums. Again, they look gorgeous. And here we have another millions of people problem. So, you know, the cervical spine disorders includes the musculoskeletal pain, basically neck pain patients, and that's everybody. In fact, if you have a pain in your neck right now, 25 million other people do right now. Like any, right? So you're sitting in your dash, you're like, oh my God, my neck. Just think you're one of 25 million. Right at that second, everybody's having pain. So some of these people will get that pain into their ear, and then we have the new generation of texters. I mean, so if you see, I think the bottom line, so this person, I don't really like to send a lot of people directly to the chiropractor. I don't have anything against the chiropractor, but I really just feel like if it were my spine, I'd want to know what's going on there before I have anybody like tweak it. So I send him to the neurologist first. While he's going there, of course, I'm telling him to do these other things. And then once he's cleared by the chiropractor, by the neurologist, then maybe he could go back to the chiropractor. So I found this quote, because you have to have a quote. And so medicine is the science of uncertainty and art of probability. So, you know, if it's not likely, if there's millions of people with something, there's gonna be more likely that you have an uncommon presentation of something that's super common than an acute otitis media in an adult. It's just not likely. And so we reviewed the external ear anatomy, the middle ear anatomy. I think we kind of understand AOM and AOE, and then some of these findings that are dramatic, but they're not painful. And then the last thing is the very common non-otologic conditions that present with otalgia are just everywhere. And I think that's it. Is there any questions?
Recommendation for people flying and have your
so when someone tells me that they know they have eustachian tube problems because when they fly it hurts, my first question is, does it hurt when you're going up, when you're coming down, the whole time? And some of them will say it hurts going up while I'm up and when I'm coming down. And some people will only have pain on descent. So the people who have pain on descent do probably have some mild eustachian tube dysfunction that they don't notice when they're on the ground, and it's just challenged when they fly. For those people, I will try Afrin. I tell them to, I don't do the Sudafed stuff. I really don't think it helps. Maybe you have a different opinion, but I just don't like that whole systemic thing if I can get something there directly. So I have them do Afrin the night before they fly. If they're a sinus patient and they're really congested, I'll say that the day before do it twice, and then that morning do it. And then I have them stop and save those other doses for the way back. For those other people who have pain like the whole time, it doesn't have to be on descent. Some of those are actually, I think, barometric triggered migraine or headache. And for them, I've tried the Afrin. Sometimes that actually still helps. Or I'll tell them, maybe you should pack your bag 2 days before you go on your trip and not stay up till 2 o'clock in the morning the night before you go, and then maybe actually drink some water that morning. And you know what I mean? Like, I think they just get stressed out, and then they get a headache, and then they happen to be on the plane when they get it. Anything else? Anyone else?
What was that
Oh,
cell
yeah.
phone thing that you...
Oh, up here, what is the cell phone thing? It's called Cell Scope.
or auto for iPhone.
Auto, what's it called?
Auto for iPhone.
OTO.
70.
OTO for iPhone, and then the one I got was called Cell Scope. And I don't know what they do with the data. Like you log onto a website, an app, and your images go there. So, and it asks you for a name of the patient and all that. So I'm just doing initials because I don't really know. I couldn't get an answer of what they're doing with the data.